But looking ahead here, I want to introduce Dr. Wendy Dean again from the Moral Injury in Healthcare Foundation. And she's going to bring what Dr. McNamara mentioned in terms of history into view and focus, particularly in really defining what moral injury is and what it means to lose a profession and what a profession really is. So I appreciate Dr. Wendy Dean being here, and just looking ahead, we'll have a short break after that. Dr. Ming Lin will talk about his experience in silencing of healthcare workers in corporate America. We'll have a couple of other talks after that, and a short break and breakout sessions, and we'll get to some solutions as well. Thanks, Dr. Dean.
So thank you very much. I'm really grateful to be able to speak with you today, and especially to talk about what the corporate practice of healthcare has done to our profession. Because we've talked so much about burnout and what practicing in healthcare does to us personally, but I want to take it up a little bit higher so that we can talk about what this means to us as professionals, as physicians. And the reason I started doing this work was because I had personal experience of what it was like to practice in this way, both in the emergency room and as a psychiatrist. I also had the experience, which really resonated with what Bradley Short said, of being the family member of a patient who was gravely ill and feeling like I couldn't leave his bedside, wondering what would happen. And as we have talked about a lot this morning, this didn't start with COVID. The controlling of staff, supplies, and space, paring them down to the point where we were incredibly lean, was an irritant every day in healthcare. What happened with COVID was that we weren't prepared for the surge of patients because we didn't want that supply or that staff to hit our books every quarter. And so that tight staff, stuff, and space became catastrophic. And I just need to recognize that we've lost a lot in the last 18 months, and not a small portion of these are emergency physicians, emergency healthcare workers. Worldwide, 115,000 healthcare workers have died of COVID. That represents $4.5 billion in education costs and 1 million years of experience that we've lost. And it has caused enormous distress. Even prior to the pandemic, 50% of doctors said that they were burned out. 2/3 said they were happier outside of work than at work, and 2/3 plan to leave practice within the next 5 years. There's also a very human cost of the crisis. Our patients know when we aren't happy or when we are struggling with the demands on us. Patient satisfaction is 2 times lower for physicians who acknowledge being burned out. And there's a crisis that a lot of folks have talked about in the past couple of years, especially about 400 physicians per year dying by suicide. But when we talk about 1 in 2 workers who are distressed, it really says to me that this cannot be a personal issue. Half of our workers can't possibly not know how to take care of themselves. This is something about the environment they're in. But what is this thing we keep talking about? Burnout has been everywhere. It is a ubiquitous term, which is part of the problem. And it's a constellation of exhaustion, ineffectiveness, or lack of accomplishment, cynicism, and detachment. The problem I have with it, and that my organization has with it, is that it has become so colloquialized as to have lost its definition. It's about individual frailty. And for most of the people that we talk to, it doesn't resonate. It's also more about effects than about causes. It's like seeing this truck and saying, oh, yes, it was in a crash, but not asking, why did it crash? Which reminds me of the river parable, where there's a physician who's standing on the side of a river, maybe having a nice day off, and sees someone floating down the river who is in distress. They pull them out, they start resuscitating them, and another person comes down the river again. And then another, and another, and another. And they're so busy resuscitating the folks who are in the river that they don't have time to go upstream and say, who's pushing them in? Or should we fix the things that are causing them to fall? And there are plenty of things in medicine that are causing us to slip into this river of distress. The practice metrics that have been mentioned before, productivity, the EMR, patient satisfaction scores, fewer staff, less autonomy to care for patients the way we know they need to be, and less latitude. We are damned if we do and damned if we don't. So when I see that wrecked truck in the analogy, what I think is the cause is simultaneously knowing what our patients need, but being unable to provide it due to constraints that are beyond our control. We are not being allowed to practice as we were taught. And to me, this sounded an awful lot like moral injury. Perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. It was a concept that was developed in relation to Vietnam veterans who had come out of the war and were being treated for PTSD, but the treatment wasn't working. So there was a reframing of the condition to this concept of moral injury. In medicine, those deeply held moral beliefs are the oaths that we took to put our patients first. So what happened in Vietnam? Because it has relevance, I think, to what we're experiencing in healthcare right now. And I don't want anybody to confuse Robert Strange McNamara with Dr. McNamara, who's speaking today. Just want to get that clear. He was the Secretary of Defense between 1961 and 1968. He was largely responsible for what happened in the Vietnam War. He was born in 1916, went to Cal Berkeley, got his MBA at Harvard, spent a year at PricewaterhouseCoopers as an accountant, and then 1 year out of business school, went back to Harvard at 24 years old to be their youngest professor. From there, he went to the Ford Motor Company as a whiz kid to help them dig out of a hole that they were in. And what he did at Ford was to reduce a lot of complex strategy to spreadsheets, to help folks who didn't understand the strategy to look at numbers that were very black and white, very cut and dried. You could see what was progress or what wasn't, what was winning and what wasn't. He then took that strategy from Ford and he applied it to the Vietnam War. And as Republican Senator Barry Goldwater said of him, he was one of the best secretaries ever. He was an IBM machine with legs. Now, we can argue about whether that was a good thing. I would suggest it maybe wasn't. But that reducing the complexity of war down to simple numbers was very appealing to a lot of people. And it ended up in this notorious metric of body counts, which, by the way, the folks who are experts in the military and in war, generals, only 2% of them believed that those numbers were really useful in any way. They all knew that they were gamed and inflated. And what ended up happening as a result of these pressures to perform was an absolutely horrible tragedy, the Melaye Massacre. Between March 16th and 19th of 1968, almost 200 civilians were massacred, mostly women and children, some elderly men. And what was worse than the massacre, which was bad enough, was that for a year, leadership tried to cover it up. It was broken by Seymour Hersh in a dispatch news service in June of 1969 and caused the Pentagon no end of embarrassment, frustration, and caused them to ask for a deep investigation into what had happened. So General William Westmoreland said, I want to focus attention on the state of discipline, integrity, morality, and ethics and professionalism in the Army. And by the way, you've got 3 months to do it. Do a deep dive. And this is actually a report that you can find online. So it's a study on military professionalism done by the U.S. Army War College. What they found was that the existing climate during the time of the Vietnam War had ambitious transitory commanders who were not skilled in the complexity of their duties. They didn't understand the larger picture of the environment that they were moving in. They were driven to produce statistical results. They didn't want to fail. They were too busy to talk or listen with their subordinates. They were determined to submit acceptably optimistic reports, which showed faultless completion of tasks. And it fell to their subordinates to figure out how to make those numbers work and to how to create those numbers, those that went into the acceptably optimistic reports. Rather than the ideal military environment of individual integrity, mutual trust and confidence, unselfish motivation of the troops, technical competence, and an unconstrained flow of information, what this report found was an environment where the individuals were selfish. They were looking upward to please their superiors. They met short-term goals by gaming and rigging. They were not sufficiently trained or expert. And there was not good communication flowing up or flowing down. And it drove this cause and effect cycle that kind of sealed what I had been thinking about in healthcare. So there are these rapid rotations, and what I mean is the administrative side of healthcare is driving some of this. So there's rapid rotations. There's no time for trial and error. Control is centralized. There's a need for numbers, reports to show people in black and white how things are going. And you end up concentrating on the trivia, which then distracts you from the real work at hand. And this gets passed down from the administrators to the frontline folks. When that report came out, the recommendations for comprehensive solutions included the concept that ethics, morals, technical competence, individual motivation, personal value systems are inextricably related and mutually enforcing. And corrective actions have to be based on comprehensive programs. And there is no choice between the mission and the ethics. There is no choice between this promise that we made as professions to deliver something to society that society has deemed valuable and the ethics of doing it. It also really pointed out the dangers of data or metrics fixation. This focus on body counts, and in our cases, the focus on productivity or patient satisfaction scores, really diverts resources from frontline producers to the managers who are measuring. Measurable is not necessarily important. So if something is easy to measure, that's what we focus on, but it's not necessarily the most important thing, which is often immeasurable. Focusing on metrics stifles creativity, it invites gaming and infighting, and short-term goal pursuit replaces high-level strategic thinking. So when we're focused on hitting those metrics, we forget about coming up to 5,000 feet or 50,000 feet and thinking about what is the big picture? What is our goal here? Who are we serving? What the Army decided to do in the context of this report was to refocus on the elements of professionalism, making sure that all of their soldiers, sailors, airmen, Marines, and Coast Guard members had technical skills, that they had socio-political, cultural understanding, that they knew who they were working with and for. They focused on human development. What is appropriate for a given age and stage of one's career? And how do we develop moral, ethical military service members? What I think is really interesting is all of this was happening right around the time when Milton Friedman published what has become known as the Friedman Doctrine, right around that same time. And that Friedman Doctrine basically said that the only obligation of an organization is to maximize the value of its shareholders. That, to me, is the start of where all of what we've been talking about today happened. So with that publication, with that statement, Milton Friedman, who 2 years later, I think, won, or maybe 3 years later, won the Nobel Prize in Economics, set the stage for profit-taking like could probably not have been imagined before this. And with that, we also saw an acceleration of the commercialization of healthcare. So Milton Friedman published his article in September of 1973. In December, the HMO Act was passed that said, it's okay, the federal government is going to support HMOs. In 1981, the first direct-to-consumer ad was published in the Reader's Digest for the flu shot, but it opened the door, it kind of blew open the door for other direct-to-consumer advertising. And then in the 1990s, consolidation and vertical integration really got a foothold and has been growing ever since. So this is a very common graph that a lot of people see. I want to make sure to point out that it's an increase in percentages. So part of the reason why it looks so dramatic is that administrators used to be a really small percentage of healthcare, but they have grown dramatically, while the number of physicians, which is the gray line at the bottom, the percentage of physicians has really stayed fairly stable. This is another interesting graph about what's happened with mergers and acquisitions. They kind of come and go, and I would bet that in the last 4 years that graph has just trended upwards. I couldn't find anything more current. But mergers and acquisitions are still a very popular way to maintain power and leverage in this arms race between healthcare systems and insurers about who is most powerful in a negotiation. Community hospitals, those that serve folks out at the the last mile, as Amazon would call it, are being consolidated. They're being put under the umbrella of large healthcare systems, and so these small communities are then becoming subject to the pressures of corporatized care. And operating margins are increasing. They're just relentlessly increasing. What this means is that the House of Medicine is divided. We have an administrative side that's doing their level best to do what they were trained to do, which is to make sure that the organization stays alive and is healthy and thriving. They follow business ethics, which are based in the Friedman Doctrine, and they're focused on profit and revenue. On the clinical side, we follow medical ethics, we take the Hippocratic Oath, and we focus on patient outcomes. The problem is that these two sides can be in opposition to each other. And patients know this. This was someone that we talked to on our podcast, who's a very smart guy, who is very savvy, who had a wife who was desperately ill. And he was in a situation where two hospital systems were refusing to work together. And they were going to have to wait 8 hours to get a medication that she desperately needed, until a government, I think it was a governor's aide.
You're going to hear people now talk.
Came to the rescue and forced those two hospitals to work together. But he said, as a layperson, I see one hospital here and I see one hospital 30 minutes away. I don't know what the difference is. Why aren't they working together? And then I realized later that they were in competition with each other, and my wife was the one who was suffering. And it's because these challenges in healthcare require us to practice in certain ways. So how do we bring change to this? First, we need to make sure that our language is appropriate. And the reason for that is it helps people feel understood, which is one of their basic needs. And the best way to understand people is to listen to them. The best way to show that you're listening to them is to use their words. So when people say that burnout doesn't resonate, but moral injury does, the best thing we can do is use their own language. The other thing we need to recognize is that the National Academy of Medicine in October of 2019 could not recommend any set of systemic interventions that would significantly address burnout. What we're doing isn't working. An article by West et al. In July of 2020 acknowledged what we all already know, which is that physicians are significantly more resilient than the general employed population. And the kind of subtitle to this is that resilience did not protect those physicians in this study from burnout. But the challenge is, as Dr. Moreno said earlier, that change is about choice. It's about choosing. It starts with empathy, but it has to be more than that. We have to choose to do different. And, we have to go beyond applying that Band-Aid to making a long-term difference. And this was also what Dr. Shaw talked about, that it isn't easy. We have to learn about things that we might not have a lot of interest in, but that are critical both for taking care of our patients and for taking care of ourselves, and for making sure that we leave our careers, leave medicine as a whole better for the next generation. One of the things that I really would like to see happen is that our current culture asks clinicians to be answerable to finance, operations, regulatory, the safety office, the risk management, about how they're protecting the organization. Instead, what I would like to do is return to the original reason why we brought administrators in, which was to support the clinician-patient relationship. So having risk management, the safety office, regulatory, the SVP of operations, and the chief financial officer asking clinicians, what can I do to make sure that you're successful today? And then delivering it for them. We also need clinician leadership who are player coaches, so they can speak with authority about what their clinicians are experiencing because they did it an hour ago. That have the mindset to break down barriers, not explain why they're there, and to develop new talent coming up. We also need to find systems that facilitate care, not get in the way, and we need to come together. The National Academy of Medicine report was really clear on that many different aspects of the healthcare environment have to work together to improve professional well-being. And as Carlina Rivera said, who is the chair of Health and Hospitals, Community resilience is really, it's really critical to making change. Start in your house, then your building, then your neighborhood, then your city. And I would also encourage us to refocus on professionalism. We're good at technical skills, but as we get busier and busier, the other components of professionalism start to fall away. And this isn't about how we dress and what our hair color is and what kind of earrings we wear or whether we wear, you know, what kind of shoes. This is about how do we understand the people we serve? How do we appropriately develop people toward leadership? And how do we make sure that they have a very solid moral and ethical foundation? So the takeaways are the clinicians were in distress before COVID. They're going to be in distress after COVID. This isn't a pandemic problem. Getting the language right matters. Moral injury means systems change, not individual solutions. And change is about choosing differently. You can find more here. And I'm happy to take questions.
Thanks, Dr. Dean. This is, we're also doing excellent on time, but this really puts it in perspective with that 50,000 foot view, and how we're honestly losing a profession. We do have some chatter in the comments here about not-for-profits, but if anyone has any specific questions here. And Dr. Patel, it's good to see you here. I know you had to work today. But this is what we're really getting down to, I think, Dr. Dean, is really the conflict of like short of shareholder supremacy, or the conflict of physicians taking an oath and business interests doing their part. So I really appreciate that.
I feel like it's, you know, what we're being asked to do is to forsake and to give up the vision of what the profession was that we were going into. Right? We thought we were going to go and be able to help people at their most vulnerable, and instead we're being asked to meet corporate metrics.
Brad, I think you should be able to unmute yourself and use your video if you'd like to ask a question. We have a couple minutes before our next talk. Actually, break.
Perfect. Dr. Dean, I can't thank you enough for this stellar presentation and I think explanation that will hopefully have people have more of an imagination for where the roots of the problem lie. My question really is in regard to the metrics that are collected, the voice surveys that we are asked to fill out, and the corporate mindset around healthcare, especially as many of us have been trying to push for change in that regard. My question specifically is, what metrics on individual healthcare workers, team dynamics, turnover, patient outcomes, how do you feel that we can actually integrate those in more meaningful ways, or even create new metrics and integrate them to catalyze change?
So I think the first thing we need to do is to get rid of about 2/3 of our metrics. Because what they're doing is they're asking us to focus on the things that don't matter to patient care. They matter to business, but they don't matter to patient care. And so once we get rid of the things that don't matter, then we start looking at things like, would you recommend that a friend or family member come to your organization for healthcare? Do you feel like you have the latitude and autonomy to practice as you were trained? Do you feel like you have support from your administration to make the changes that need to happen to keep your patients safe and to get them the care they need? So I think I would like us to start thinking about really what matters to the patient care that you'd like to do, and is it measurable, and if it is, how? And what we found is that we don't do very much quantitative measurement. We do a lot of qualitative measurement, and that gives us significantly better responses, although it's harder and it's more expensive.
Thanks, Dr. Dean. Really appreciate the talk.